So under the FTC Act, an act or practice is deceptive when it, 1, misleads or is likely to mislead a consumer, 2, a consumer's interpretation of a representation is reasonable under the circumstances, and 3, the misleading representation is material. So Josh and Glenna, can you tell us about some of the representations that providers have made in regard to so-called gender-affirming care, both the need for it and its effects?
Yes, thank you, Commissioner. Thank you. First, I just want to express gratitude to the FTC for holding this event today and for inviting me to be on this panel. We've heard a lot of deceptive representations all day today. The other speakers have been identifying them accurately, in my opinion, all day. I'd like to drill down on some of the foundational false claims in gender medicine that really show us that the problem goes all the way to the root of this practice. And this can actually be awkward to focus on because the false claims are not just made by gender doctors. In much of the country, that jargon is part of our normal lexicon now. For example, sex assigned at birth. Lots of everyday people are using it because they think it's the nice thing to do. But once you realize how harmful gender ideology is, I think that people can maybe start trading in those phrases. So I'll start with sex assigned at birth. The doctors ably handled this one earlier. Sex is not assigned at birth, so that is a false statement. The words assigned at birth imply that sex can change. So for young patients, especially in a gender clinic, they show up because they want to change sex. And when doctors tell them sex is just an assignment, they get the idea that they'll be getting a sex change. And it's important to note under the FTC Act that it does matter who the target audience is. So even if you're an adult and you think, well, that phrase is innocuous, I know what sex assigned at birth means, I know it's just meant to be nice, well, we must look at it in terms of the patient population that's hearing it, and these are distressed children, so it is deceptive toward them. Second, this is a big one, gender identity. Doctors claim that consumers, patients have a gender identity that is incongruent with their body. But it's impossible for gender identity to be different from a body or the same as a body because gender identity, the way it is defined by gender doctors, has no definition, it has no properties. So this is an important point. I think a lot of people assume that gender identity means wanting to be one sex or the other. And gender doctors almost make it look like that's what they mean because they say that gender identity can be male, female, or something else. But it's a trick because remember, gender doctors think that a male is anybody who says they're a male. So it's a circular definition, like gender identity is somebody who has a male gender identity kind of thing. And then the doctors just double down on their deception when they try to kind of add more verbiage to make it seem like gender identity does have properties and it's not just a circle. So just to give you some examples, Jack Turbin wrote in the New York Times that the most basic part of gender identity is a person's transcendent sense of gender. And this was the New York Times, and he did not define the term gender after referring to the transcendent sense of it, instead writing that gender, quote, goes beyond language. Another gender doctor, a pediatrician, wrote that gender is a, quote, multi-dimensional concept with complex expressions, and that it is related and distinct from sex in ways that modern science is still exploring. So she's going to know the definition of gender in the future, once science is done. And just a side note on that, I'll try not to go on too many tangents about this, but a lot of times gender doctors will kind of use language to imply that they're going to get the answer to a gender question soon. Science is almost there. And they say, look, this is like a really new area of study. It is not. All this stuff goes back to the early 1960s. It has been, really, institutions have been investing in it since then, like, major universities. It's had very little change in the theories underlying it since the early 1970s when they coined the term gender dysphoria. So whenever they try to use that excuse of like, oh, we're new, like that's not true, they're not new. This stuff is all very old, it is not cutting edge. And finally, I'll just give you one more example. Daniel Schumer, a pediatric endocrinologist in Michigan, he doesn't have a coherent definition of gender either. And when he was deposed recently, he admitted that when he explains gender to patients, quote, "I have oversimplified." So he's not as complicated as the woman with her complex multidimensional concepts. He boils it down to some other not true thing. So with all that being said, it seems safe to say that patients don't know what their doctors mean by the term gender, and doctors don't really have any meaning. They seem to be using it as a placeholder to lead the patient to believe that, since they have this gender-related problem, they need a gender-related solution, which is gender-affirming care. So that's kind of the function it's serving. I think that whenever you see the term gender, pretty much in the gender world, the gender medicine world, it's deceptive. So then I'll just give you one more kind of foundational false statement that they make. And this is from, for example, the American Psychological Association and the American Academy of Pediatrics. They claim that sexual orientation means attraction to a gender. Sexual orientation, there's no scientific basis for saying that. The studies are about sex, sexual attraction to people based on their sex. And recall, gender doesn't have a definition, so it's not even possible for that claim to be true. And this is really important because it leads consumers to believe that gender-affirming care will allow them to date and form relationships as though they were members of the opposite sex or a non-binary sex. I'll try not to go off on that. So this is playing out in the real world. In the gay community, we see these young women pursuing gay men, trying to form relationships with them. They think it's viable because they have a male gender identity. Their doctor told them so. And these institutions are telling them that sexual orientation is based on gender. So this just leads to a lot of discomfort and sadness and awkwardness for parties on all sides of this equation. And that's putting it mildly. So again, this is a really material deception that is being imposed on these young people.
Thank you. Josh.
Thank you, Commissioner. I would like to look at both the problem that's presented by the people making these statements and the solution. And the deception is when viewed in the round, but you can look at it from both angles. They state the problem as your child is going to commit suicide if this intervention is not carried through and if you don't agree to this. And then they come along with a solution that they say is rock solid. So you have a drowning victim, and here's the life raft. And because a deceptive communication is viewed holistically, it is a clearly deceptive message. The message is, you are dying, and here's your life raft. That is the core deceptive message. Another angle of this from an aspect that the FTC is well versed in is implying that something is FDA approved. And again, when viewed in the round, you're in a doctor's office, somebody there wearing a white coat, exercising authority over you, presenting a life raft to you, you are assuming this has every conceivable seal of approval out there. And there is no inkling in the parent's mind or the patient's mind that the FDA hasn't vetted this and has not approved this. And so to not have a disclaimer that this is absolutely not FDA approved, not even really reviewed, it's entirely an off-label use, and as one of the bits of evidence from earlier today, the whole thing is off-label. That's a disclaimer that's vital, and it's not being made.
Thank you. Switching over to unfairness, under the FTC Act, an act or practice is unfair when it, 1, causes or is likely to cause substantial injury to consumers, 2, can't be reasonably avoided by consumers, and 3, isn't outweighed by countervailing benefits. So I was hoping Brandon, Paul, and Jay could tell us a little bit about some of the injuries that are alleged to have followed from the push to get young people into aggressive gender-related medical interventions.
I'll go first, and I would like to thank you, Commissioner Metter, and the FTC for this event today. The injuries are incredibly brutal. I've seen things that have put gray hair in my black hair, and it's just, you'll age pretty fast. You don't want to see the kinds of things that I see in my inbox and I hear from parents about what has happened to their children. And I'll say, when we talk about unfairness and deceptive trade practices, because it is based on an irretrievably flawed premise that it's actually possible to be born in the wrong body, any medical treatment toward that end is going to do damage, guaranteed, full stop, because it starts with a lie. That's just it. And it leads to horrors that I'm about to describe. I'll just talk about 3 injuries that I've seen. I haven't seen fully, but I've seen part of it and heard about it. One detransitioner man who walked into his appointment, he was reportedly told by an intern working in the intake office, if you think you're trans, you are trans. He went fully down the trans path. His story was featured in Abigail Schreier's book, Irreversible Damage. I also reported on his story. Hormones, wound up getting an orchiectomy, the removal of his testicles. And he was never told, even during his appointments, they never used anatomically correct language during his appointments. They castrated him for $1,000. That poor man had severe suicidal ideation in his postoperative regret, severe endocrine complications, and he even, when he tried to have sex, wound up ejaculating blood. And to this day, the weirdest email I've ever had to send was to Dr. Laidlaw asking him if is it really possible to ejaculate blood. And yes, it is, after you've been castrated. Another woman on Instagram who was led down this path had a phalloplasty surgery and ended up having to have over 24 quote-unquote corrective revision surgeries because they so badly mangled her down there that she had to urinate out of her anus into an ileostomy bag. And she was posting about this carnage that was done to her body on Instagram. It's gruesome. Another woman who's got the worst story I have ever heard about, and she's featured in the documentary podcast that I produce and host. I can say her name. Her name's Amy Atterbury. I just have to honor her because it's the worst story I've ever heard. She had to be in the next room over where doctors disfigured her daughter's forearm to make a fake penis. Medicaid paid for her to have a double mastectomy and all of her reproductive organs cut out. But her daughter's forearm was cut up to make a fake penis, and she had to be in the next room over for 13 hours as the doctors did what they did to her. And reportedly, I've heard that there's some other corrective surgeries going on that are either planned or may have happened. They're currently not speaking as far as I know, where they will have to do some sort of revision where they cut the sex organ in half and reroute her urethra. You want to talk about, I totally try to avoid making any comparisons to the Holocaust because I just don't like to, that's a uniquely horrible episode in history. But I will sometimes be emailed by Jewish readers who say, we're living in a culture of Mengele's. This industry needs to be dismantled from the top to the bottom. Because it all begins with deception and a lie that it's actually possible to be born in the wrong body, and there are products and services that are marketed to that end.
Thank you.
Well, I knew we were coming at the end, and probably the harms would be discussed in exquisite detail by other speakers and panels. In fact, Aaron Friday said almost everything I was planning to say just prior to this. But so let's just briefly summarize the manifest and obvious and documented harms of so-called gender-affirming care. We won't even talk about the social transition. So just puberty blockers, cross-sex hormones, and surgery that have been discussed in this room today. Reduced bone density and bone strength from puberty blockers. So the state of Georgia didn't include puberty blockers in its bill restricting these procedures because the sponsor had been told that it was entirely reversible. Puberty blockers are just reversible. We know that's not true. You know it's not, logically, because you can't reverse time. And so if a child has his puberty blocked at 13 and his peers go through puberty and he gets off of them 4 years later. That part, at least, is obviously not reversible, and we know there's serious physiological effects of this. It likely harms brain health. This is a topic of continuing research. I happen to have seen a report that will be coming due here very briefly that focuses on the adverse events reporting system. So not the VAERS, not the vaccines, but the other FDA's reporting systems on puberty blockers. Just look at all of the reports. There are very profound and underappreciated effects on mental health and cognitive development from puberty blockers alone. Remember, we haven't gotten to cross-sex hormones yet. There's psychological distress. There's obviously infertility, at least if these are continued, and insofar as they're the beginning of a treatment pathway that leads to infertility. Stunted growth, which is at this point quite well known. So now let's turn to cross-sex hormones. Again, fairly well known already, heart health risk. We don't have long-term data on this by definition because we're in the beginning of the experiment with doing this with kids, giving girls massive amounts of testosterone. But we can be quite certain that it's going to have a signal in heart health. Infertility, for obvious reasons, seems to be a serious increase in cancer risk, which is also discussed today. Mental harm, so many detransitioners, especially females, will talk about an initial euphoria from testosterone. Same thing that men that get testosterone supplementation will experience. But this is sort of a honeymoon, and a year or two in, many detransitioners report actually quite harmful and distressing mental effects. Again, the sort of regret and detransition was not supposed to happen, but cross-sex hormones has very specific physiological effects. Some of the detransitioners that spoke today, for instance, commented on the depth of their voice, which in the scheme of things may seem superficial, but it's a reminder of the kind of permanent effects that these drugs have. And then almost inevitably, when we get to the surgeries, this is sort of obvious, and Brandon's given us a few examples, but these are not one-and-done surgeries. Most of us who've had surgery, I had to have a quadricep tendon reattached to my knee in 2019. I had one surgery and a few months of recovery. The so-called gender-affirming care, in which you create facsimiles of the other sex or no sex, depending on what the doctor's sort of metaphysical theories on these things are, right? That's not a one-and-done. These usually require maintenance. They very often require follow-up. They may, in some cases, and I know there are detransitioners in this room, involve years just trying to heal the wounds from the initial surgery. That's the reality of this thing. And then the one thing that was not discussed quite as explicitly as I think it should be is that there is an iatrogenic harm to the beginning of this procedure. So just puberty blockers alone, even if they were by themselves reversible, we know that if a child is put on the transition pathway and starts taking puberty blockers, he or she is much more likely to continue down the pathway to full transition. So in other words, it fast-tracks children based upon a really bizarre and almost certainly false diagnosis all the way to the end. So the question of whether puberty blockers alone are sterilizing doesn't quite answer the question. Even if they weren't, if it fast-tracks kids onto a protocol that leads to sterilization, then yes, they are. These are manifest harms. Now, any surgical or medical intervention has risks, so why would anyone sort of be willing to bear this? It's almost certainly because of the false calculus that parents are presented with. If you're a parent, and I will say I'm someone that works on this issue, I have no personal connection. I don't have a child or family member that has struggled with this. I do know this as a parent. The worst scenario you can possibly imagine for your child is suicide. And so if you think, okay, suicide's the worst, and then you're told by a trusted physician, I have a way out for you, though. It sounds terrible in the abstract, but it will prevent the worst outcome. It's only with that emotional blackmail, I think, that most parents would ever have entertained starting this process in the first place, and it's precisely why the FTC has relevant jurisdiction on this issue.
Thank you.
So yeah, I don't know what else to add about the harms, the obvious harms that this causes. I mean, I think, the panels we heard before this, what Brandon and Jay just talked about, I mean, the harms are numerous and obvious. I don't know if I'd be preempting you, Mark, by jumping to the second part of the definition of what makes a practice unfair, that it can't be reasonably avoided by consumers. So when Erin was up here earlier, she mentioned Dr. Johanna Olson-Kennedy, how she said that she wouldn't have any issue with transitioning patients who would later regret it because, well, that was what they were asking for at the time. And I feel like that's often used, as a cudgel against detransitioners who later regret it of, oh, well, you should take, responsibility for your actions. And that kind of goes to this question, can this be reasonably avoided? And I think we have to look at the fact that the system that's been set up, it's really been set up to create a pipeline that's easy to get into and almost impossible to get out of once you're in it. And so a few things to that point. I mean, obviously, we've heard again, all the testimony earlier today about the emotional blackmail that's used at the very outset, telling parents, would you rather have a dead son or living daughter or vice versa. The patients are really just, pushed into this and pressured into it with the fear mongering and whatnot. And then the fact that they're not fully informed. So this came from a Free Press article about Planned Parenthood, which is, I think, a particularly bad actor in this. So Free Press about Planned Parenthood. Planned Parenthood's materials for clinician state atrophy can begin within just 3 to 6 months of exposure. But on the brief patient consent form, it's about 3 pages long, that both Hyman and Anna signed. This was referred to as only genital dryness. So there's a lack of informed consent at the outset. And then when patients are in this pipeline, they're encouraged to continue no matter what's happening. And that's, again, by design. This is from the WPATH Standards of Care 8. We recommend healthcare professionals maintain existing hormone treatment if a transgender and gender diverse individual requires admission to a psychiatric or medical inpatient unit unless contraindicated. So that means if they're going through some sort of psychiatric episode, the WPATH Standards of Care is saying continue to administer hormones anyway. And again, I think we've heard, throughout today, examples of that. And again, that's not a mistake. That's by design. That's what their standards of care states. So they're in the pipeline. They're continuing to be pushed down this pipeline. And oh, by the way, if they do have regrets, if they do want to detransition, well, insurance will cover the initial, costs of transitioning. But a lot of times, various detransition care is not covered by insurance. So there's a financial obstacle to getting off the pipeline as well. So I think when you throw all that together, you really can't help but conclude, this can't be reasonably avoided by consumers.
Thank you.